My name's Susan Hillier. I'm the Dean for Research at the University of South Australia. And firstly, can we acknowledge that we are meeting on the lands of the Kaurna people? I think most of us are, but if you are meeting somewhere else, I'm sure that you also would wish to pay respects to the traditional owners of the land on which we meet, and pay our respects to the elders past, present and emerging. It gives me great pleasure to chair this last session for the ABMC talks. My favourite colleagues are here to present on this last session, and these are from the group that I research in, so it's even more delightful for me to have them in the last session. So Professor Mari Williams is from University of South Australia, obviously, and she's worked there for a number of years, Mari. And has established a long and consistent collaboration across the state and the country, and in fact internationally, in the area of chronic obstructive pulmonary disease, and now in particular breathlessness, which, Mari, I just learnt to say dyspnea, and now I have to say breathlessness. So
yeah, no
need to change. So I'll invite you to start sharing your screen. Mari will talk for about 8 minutes, and then I will open for questions. Okay, over to you, Mari.
Sure. Well, thanks, Susan, for actually giving me the opportunity to talk about what our group actually does. And obviously, I'll just give a little spiel about Impact, which is the research group that we're actually involved in. And this group is, our vision is really to actually enable and empower people with chronic conditions to reach their potential for recovery, independence and well-being. And at the moment, there are 4 grand health challenges. So I lead the persistent breathlessness stream. Lorimer leads the actual persistent pain stream. Rural health is led by Esther May, and obviously stroke recovery is led by you, Susan. So why persistent breathlessness? Well, it's a really horrible sensation, and it's not the same as the feeling you might have if you've run up the stairs or you're a bit breathless at the gym. And it's not a single sensation. So this is a figure which is words volunteered by reasonably similarly aged matched people with and without lung disease or COPD. And what you can actually see at the top of the figure is these sorts of words were only volunteered by people who don't have lung disease. And the words at the bottom of the actual figure were the words that were volunteered by people who actually live with chronic lung disease. And then you've actually got a mix of words in between. But I might just draw your attention to those ones highlighted in red. So these sensations of tightness, work of breathing, suffocation or air hunger are the 3 big sensory qualities that are known about in breathlessness, and they've each got a different neurophysiological mechanism. So just to recap, it can be a really horrific sensation, and it's complex. There's a whole lot of information that can be coming up from your body into your brain, and then your brain having to actually process, what's this mean? Have I felt this before? Should I be worried about this? How frightened am I by these sorts of messages? So it's a sensation or a perception that's got both a biological, if you like, that physiological part of your body, but it's also got a very big cognitive and emotional integration when you get to the brain. And it's really common. So it's very, very common across a whole range of chronic health conditions, and it persists despite optimal medical management. So you can be getting the best of care, but you will still have breathlessness. So it's not a curable sensation, but we can certainly try and do something to make it less disabling and less distressing. It's really important to recognise that it doesn't have, this sensation doesn't have a one-to-one relationship with the severity of the physiological damage. And it's a really strong independent predictor of mortality. And it wouldn't be a presentation in 2020 without mentioning COVID. And COVID has really focused people's minds on this sensation, both as an acute marker of illness And also we're starting to see more and more data about how long this persistent breathlessness can go on in recovery. So what's our group actually do? Impact uses this cycle to actually explore and help people. So we cover off on a whole range of approaches. So we do both quantitative and qualitative type approaches. We do primary data collection, primary studies, as well as secondary analysis. But we really want to prioritise low resource translatable strategies to help reduce distressing breathlessness. So I'm just going to step through a couple of the examples to illustrate that cycle. So some of the things that we do to actually understand the problem and develop new solutions are obviously systematic reviews to find out what is the evidence for X, Y, Z. We do consensus type approaches like Delphi's to actually get a handle on what might be the most important thing from an expert's point of view. And I'd just like to point out one of our adjunct research fellows is Hayley Luthwaite. Now this paper is very recent and it doesn't come from our group. It's work she's actually done with Dennis Jensen at McGill University in Montreal. But I just want to highlight Hayley is quite unique and very talented in that she's female and she's an exercise physiologist. A couple of our current PhD students are really starting to look at novel strategies for helping this distressing, disabling sensation of breathlessness. So Alicio is actually looking at a very novel form of exercise, blood flow restricted exercise, which means that people can exercise at a much lower intensity and still get bang for their buck, so still get a physiological training response. Dan Johnson is actually starting out a program of research all based on menthol. And menthol is a very interesting substance because it's got cooling properties and it seems to induce a cognitive illusion of airflow. In terms of examples of how we test new solutions, so we look at things like cognitive behavioural therapy for management of dyspnea, okay, or chronic breathlessness. We look at the tools that people use as outcome measures for assessing this health professional education in terms of upskilling and building capacity in our workforce for managing chronic breathlessness. Now this is a very small photo of Kylie Johnson, and also pointed out is Sarah Booth. And Sarah Booth is one of our collaborators who was one of the instigators of breathlessness intervention services in the UK. In terms of implementing new solutions, again, and this is a very good follow on, this is a current project that we were implementing a home-based breathlessness intervention service based on the Cambridge Breathlessness Intervention Service developed by Sarah Booth. And this gives me an opportunity to point out Mary Young, who's an adjunct senior clinical fellow with Impact, and Mary's an amazing respiratory nurse practitioner. In terms of the last part of the cycle, identifying real world problems or clinicians as scientists, we're really interested in hearing from either people living with breathlessness or clinicians who work with people who live with breathlessness in terms of ideas or things they'd like explored. And we'll work with people right from very early ideas in terms of what they're starting out with their idea is. We'll work with people right through to actually try and set up protocols or implement pilot studies or start the implementation process right through to clinician-led submissions for grants. So that's been a very quick overview of what we actually do. We're very happy to be contacted, so you can contact me either by email or Kylie Johnson.
Great. Thanks very much, Mari. I'll just watch the Q&A to see if there's any questions.
Sure.
People are notoriously quiet, is my experience, but maybe they'll prove me wrong. Could you tell us a little bit more about that clinic so that I know that you receive funding through the HTSA, and there was a clinic set up down south. I'm just interested to hear how that's got on, and what's.
Yeah, so this was almost a translation piece of trying to see whether the Cambridge model for breathlessness intervention services would translate well into the South Australian health system. So it was home-based, and we looked at recruited people who had breathlessness, predominantly COPD, who had multiple admissions in the last year. And so Kylie Johnson and Mary Young then went out to their actual houses, listened to what their problems were about living with breathlessness, and actually started very small, very efficient, effective evidence-based interventions like handheld fan, like positioning, like actually pacing, and trying to actually get people to exercise more within their capacity. And we're still analysing the data, but certainly the actual immediate feedback. So I did the independent follow-up interviews with people to ask them what they thought, how they found it. And overwhelmingly positive in terms of felt like people were being heard, really provided practical strategies for making this sensation more bearable, being able to cope. And on the whole, most people, in fact, were able to do more, get out of the house more, do their shopping. The memorable interview was somebody who, in fact, was able to go to the pokies and hadn't actually been able to do that for the last 12 months. That's a big win. That's a massive win.
Yeah. I wonder if that's in one of the quality of life things, increased participation at the casino. Okay. All right. So as predicted, the chat room is fairly quiet. So thanks very much, Mari. It's great it's terrible that we share a building, and we have to come to a talk like this to catch up on what you've been up to. But congratulations on all your great work, and all the best for the future. Our next speaker is Dr. Brenton Hordacre, who is an early career fellow on an HMRC fellowship at UniSA, also in impact and in the area of stroke recovery. Brenton did his PhD at Flinders, then worked at Adelaide Uni, and now works at UniSA. So he is ecumenical, let's say, in his religious background. So I'll hand over to you, Brenton.
I usually say I've gone to all three universities, so I could tell you which one's the best. But
okay, well, we won't ask that question.
No, they're all good actually.
Yeah, perfect. Yeah.
So yeah, thanks very much, Susan, for the opportunity to do this. So I'm speaking, I suppose, on behalf of Susan, who actually leads the stroke recovery theme within Impact. So Mari introduced Impact before, and there's the 4 pillars, and I'll speak about the stroke recovery side of things within that. First of all, I thought I'd start with why are we interested in stroke recovery. I think there's some pretty key statistics. So it's a global leader of adult disability. 1 in 4 people now will experience stroke in their life. So that's people over 25 years of age. So if you think of, 3 or 4 of your friends, statistically, one of them is likely to have a stroke. Currently in Australia, we're up to 50,000 strokes each year. 500,000 people living with stroke, and that's going to reach 1 million by 2050. So those numbers are sort of on par or ahead of what we see with Alzheimer's disease and dementia. Unfortunately, a large percentage of people who experience stroke are of working age, so they're becoming younger and younger. So we have to consider those aspects when we look at recovery and how they're going to get back to participating in their life. And there's obviously a huge economic cost as well. From a personal perspective, I think, and this is probably true for anyone in Impact, I think we do a lot of this stuff because we actually care about the people that we're working with, whether that's breathlessness or pain or stroke recovery, and also trying to help the clinicians that are working with them every day. So Mari did a great job at introducing this model that we use for research really around the 4 pillars. So for stroke recovery, we have that same model. That's understanding the problem, developing new solutions, then testing those solutions, implementing, and then of course there's the PRISM adaptation, which is the clinicians, the scientist as well. So really briefly, I'll just go through those, but I'll talk a bit more about the projects in the next couple of slides. So for understanding the problem, we have a few techniques that we use commonly, I suppose. So EEG, neuroimaging, blood tests, behavioural and cognitive experiments, and also outcomes as well, and then data linkage projects. So you can see there's a few projects there about understanding the problem of stroke recovery. So one of those is one that I'm involved with around cortical connectivity as a predictor. Susan, as well as Inez, I think as well, look at, Susan looks at augmented visual feedback, and then how we understand neglect from Lindy Williams, cognitive reserve from Emily Rosenich, and then also looking at services relative to outcomes in metropolitan and rural settings. A few trials, which I'll talk a little bit about as we go through, and then how we implement some of those solutions. So you can see things down there like yoga and music therapy, and the SENSE trial, which is currently running now, but it's like a sensory training skill set, I suppose, that we're training people up in and then delivering that service clinically at City West. And I mentioned about the PRISM adaptation before, which is that clinicians as scientists, so working with the clinicians to help them understand what the problems are and then how they can implement solutions to their problems. So it is this nice, cyclic sort of system where we hopefully can improve the way we help people with stroke recover. So I'll go through a little bit more about each project now. So this first one's around, comes under the category of understanding the problem. So you might have heard of cognitive reserve, and it's probably more commonly known in the Alzheimer's or dementia recovery. And the idea behind it is that you have this capacity within the brain that might be able to withstand the pathology. So as you get more and more white matter plaques, you might be able to behave the same, but at some point you're going to change your behavior. And that's different for everybody. And it might come down to this thing called cognitive reserve. So how much flexibility is in your brain to compensate for that pathological load. This is the work of Emily Rosenich as well. It's her PhD. And she actually looked at that in stroke recovery. And what she found was, hopefully you can see my mouse. You can see there's this interaction between cognitive reserve, stroke volume, and something called the functional independence measure. So that's a recovery measure. So she tracked people with stroke for 6 to 12 months after their stroke, measured cognitive reserve, and you can see that along the x-axis, so higher scores, higher cognitive reserve prior to stroke, and then looked at their recovery. So you can see if people had a relatively minor size stroke, so low pathological load, so scores of 1s and 2s, there wasn't really any relationship there with cognitive reserve and recovery. But it wasn't until the stroke volume became larger that you saw that relationship there, and that's that greeny coloured line, aqua, I'm not sure what colour you go there. And it's what that says to us is that when the stroke load or the pathology becomes larger on the brain, those that have higher cognitive reserve are able to compensate for that more and recover better after stroke. So it does fit that same sort of model. It seems to buffer the impact of stroke pathology. And I think something that's interesting from this is that cognitive reserve is actually modifiable as well. So it might give us something to do in terms of testing new theories going forwards for treatments. This is a little bit of work that I do around plasticity. And this is actually back at my time at Adelaide Uni as well. So we looked at plasticity of the motor cortex after stroke. And you can see here that we measure plasticity using some neurophysiological techniques. Bigger numbers mean more plasticity, and this is the timescale after stroke. So very early on after stroke, there is this increase in capacity for plasticity, and that sort of tails off over time. And that fits really well with those animal preclinical models that we see as well. So the question for me is really, can we, that tells us something about the problem of stroke recovery, because that's, that correlates well with what we see in terms of behavioural recovery. So we know that increases in plasticity allow us to recover better. But can we do something to extend or reopen that window at a later time frame? Because then maybe the therapy that we do in chronic stroke would have more value in terms of recovery that someone can achieve. So in terms of investigating, understanding solutions, you can see there's quite a few things. So brain stimulation, exercise, motor imagery, pharmacology, and we're certainly interested in the biomarkers and mechanisms of how those potential treatments work. And just to give you a bit of an idea, here's some data from one of our home-based brain stimulation studies. So 51 chronic stroke patients. So that's the people outside of the window of plasticity. And those that had the sham treatment, not much change in their behaviour, but when they had the active treatment, there was a bigger increase. This is work of Ines, so body awareness training. So body awareness is, you know, your perception of your body in space. We've all got this perception. If you close your eyes, you could think about how big or small your hands may be and your feet and where they are in space. And that can change for people after stroke, and you can see some of the images there on the right. And what Ines found in her study was that it was reduced, body awareness reduced after stroke, and it correlated with recovery. But she then ran a randomised controlled trial looking at body awareness training. And you can see those in the experimental group had a bigger increase in their body awareness after the intervention. So looking at different interventions we can use to address this. This is Susan's work. This is actually Susan over here, in case you can't tell. So looking at novel ways to increase body awareness and feedback to the body. So this is an augmented reality system, and that's partnering with the Australian Dance Company. Is that right? Yep. So you can see you get real-time positional sense information about where your body is in space. So increasing that feedback that somebody gets there as they move through, in this case, shoulder abduction. And you can see there on the right arm, it's a little bit reduced. And then the final one is around, we ran a randomised controlled trial. So again, a solution to a problem is using brain stimulation to treat post-stroke depression. Brain stimulation's got actually really good evidence for depression. It's actually just received Medicare approval here in Australia. So we ran a study looking at it in people with post-stroke depression. And you can see down the bottom here as well, if I get my mouse, that those that had the sham, there wasn't much change in their depression scores, but the active group had a significant decrease. So the final bit, so implementing this stuff into practice. So how do we do that? We're starting to set up a technology clinic at UniSA, which is at City West. So we really want to do that for people with chronic neurological conditions so they can receive the best evidence-based state-of-the-art treatments to improve their quality of life. A few different purposes around, you know, rapidly implementing findings, a research testbed, a teaching opportunity. And we've got some different equipment down there, from brain stimulators to robotic devices, virtual reality as well, that's all available to people in the community after we've done these studies. But that's it from me. So certainly please feel free to contact Susan or myself. And the other thing, I've just put it in green so I remember, is the outreach tour, which is the Impact Outreach Tour. I think it's in April or March or May, somewhere around there, early next year. So Susan will know a little bit more about that, but it's a rural tour, cycling from town to town and working with peoples in the community to help them, you know, treat people with stroke better or understand stroke recovery, breathlessness, pain, etc. That's it.
I'm on mute. Okay, thanks very much, Brenton. I'm watching for the Q&A. If there's any questions in the Q&A box while we're waiting for nobody to type, I'll ask you a question about the depression study. What do you think the mechanism of effect is with TMS and the reduction in depression? That's a curvy one for you.
Yes, it is, because so if it was someone that didn't have a stroke, what we would say is that the left dorsolateral prefrontal cortex has shown hypoactivity, so reduced activity, and the type of stimulation that is applied is to increase that activity. So to basically, there's an abnormality and you're trying to treat the abnormality. The problem is with stroke, and you're on the paper, Susan, so you know about this, but there's this, whether the stroke is actually caused by, the depression is caused by neural changes or functional changes in the brain, and how much damage has occurred in that prefrontal brain region, or is it actually a response to the devastating impairment of experiencing a stroke? And the response to that sort of treatment might differ depending on what's caused the depression. So we're looking into that in another study.
Okay, last call for any questions from the audience. I'll just mention a little bit the Rural Outreach Tour. So this is a traditional thing that the Body and Mind group, as part of Impact under Lorimer Mosley, have done for the last 3 or 4 years. Is done an extensive rural tour through, one was in Victoria, Tasmania, I think there's been a few others, where they do an outreach service working with both clinicians and consumers, so patients. In their instance with persistent pain. So they do a dual education and support sessions in the different communities that they're cycling to talking to people with chronic pain about the current evidence base and understanding of chronic pain, but also then upskilling the health professionals in that particular town. So now that we've joined together, we're proposing to do this next year for stroke and persistent breathlessness and persistent pain. I'm personally not going to cycle through different country towns, but other fit folk will maybe do that, and probably covering the terrain somewhere between Whyalla and the Barossa Valley. So if people are interested in being involved and you have an interest in clinically or in research in those 3 areas, persistent pain, persistent breathlessness or stroke, we would love to have you on board so that we have a bit of a roadshow when we hit each town, and that we'll be running workshops for both the public and for the local health professionals. Okay, well, I think that's about it. First, it just leaves me to thank a few people. This is the last session for the year. I think this vision, this series of events is the vision of John Beltrami. So John, if you're listening, thank you so much for the opportunity. It's been a great initiative, and I hope that you feel really proud of what has been achieved and the number of people who've come and presented and entered into the spirit of sharing knowledge, sharing skills and expertise, and increasing collaboration across the universities and across the LHN. So I really thank you on behalf of everybody who's presented for this initiative, and also to Tamara, who's the go-to person to make things happen, and everybody else at ABMC. And finally, we'll wish everybody best wishes for the festive season. Hopefully we will be let out. I'm a country girl, so being let out always sort of reminds me of, letting the chooks out for a bit of a scratch. So if that's you, I hope you'll get let out for a bit of a scratch over Christmas, and have a terrific break. And we look forward to seeing you in the new year. Thank you very much for your attention. Take care.